Go ahead and get started. Welcome, everyone. My name is Syed Mehdi. I'm an orthopedic and minimally invasive spine surgeon here at Freighter South. And today I'm going to talk about some of the causes of back pain and some of the modern treatments that we have for it. So just a little bit about me. I'm originally from the Wisconsin area. I did my undergraduate studies at Emory University in Atlanta, Georgia. Then did 4 years of medical school at Case Western and Cleveland Clinic. Spent 5 years doing an orthopedic surgery residency at the University of Kentucky, and then spent one dedicated year doing a spine surgery fellowship at Houston Methodist. So the most common thing that I see in my clinic is patients that unfortunately present with back pain. And what causes back pain? So back pain occurs from a wide range of age-related degenerative changes of the spine. This can be due to wear and tear and degeneration of the discs, herniations or bulging of the discs, bone spurs or osteophytes, and then arthritis in the joints of the spine. And patients often ask, why is this happening? Why is the pain occurring now? So unfortunately, how fast your discs wear down is primarily genetic. So you can blame your parents for it. But some things that we know that can affect how fast your discs wear down is obesity and smoking. So there's a few things that we can try and control to try and reduce and limit our risks of degeneration of the spine. Why is this such an important topic? Well, unfortunately, back pain is the leading cause of years lost of disability in the United States. 40% of Americans will experience one episode of back pain in a year, and 85% of people in their lifetime will experience back pain. And every year, roughly $140 billion is lost in productivity from people suffering from back pain and disability. So what are some things that commonly present when people have arthritis-related back pain? Well, the most common is pain with activity and pain that's worse at the end of the day. Certain activities such as bending forward, bending backwards, or twisting can also worsen the pain, and that's because that puts extra stress on the discs and the joints in our back. And often the pain can radiate in a band-like pattern across the lower part of the back and will often radiate to the side of the hips and the buttock area. And again, like I mentioned earlier, unfortunately, this is due to more age-related degeneration of the discs and arthritis in the joints. Now, oftentimes when you have degeneration and wear and tear of your back, you can have pinching of the nerves, which causes radiculopathy, or more commonly described sciatica, which is pain that radiates down the leg into the foot, usually in a specific, what we call dermatomal distribution, or a specific nerve root distribution. And again, this is because the nerves in our back become pinched, and that causes pain throughout the leg. Fortunately, 95% of people that present to my clinic, I'm able to treat their symptoms with conservative treatment. And that often is a combination of physical therapy that works on strengthening the core and back muscles, medications that address the inflammation, which is the main source of the pain, and then sometimes steroid injections to, again, address the inflammation, which is the cause of the pain. But sometimes if our conservative treatments don't work, then we do have surgical options to address these problems. And one of the two major surgeries that I do includes a decompression, which involves removing bone, ligaments, or tissue that's pinching the nerve and causing leg pain and back pain. And sometimes, if needed, we'll also do fusions of the back. So, decompression surgery, the main goal of the surgery is to take pressure off the nerves and address the leg pain and the back pain. And oftentimes with these surgeries, we can avoid the bigger instrumentation and fusion surgeries that a lot of people hear about and that don't always have the best outcomes. And again, these surgeries are usually done to remove things like disc herniations, which can pinch the nerve and cause pain, or bones and ligaments that are pushing on the nerves as well that are causing pain. Now, traditionally, these surgeries were done in an open technique, which involved a large incision and cutting the muscle off of the bone. And unfortunately, when that happens, it leads to a lot of scar tissue, which can cause more pain and longer recoveries. Muscle in general is very vascular, meaning it has a lot of blood supply. So cutting into the muscle leads to a lot of bleeding and can tend to lead to higher blood losses and ultimately longer stays in the hospital. The other downside of doing open surgery is when we cut the muscle off of the bone, oftentimes that area gets replaced with scar tissue. And this is demonstrated in this MRI cut of the same exact patient. One level that didn't have any surgery, you can see all of this robust, what we call paraspinal muscle, a muscle that's attached to the ends of the spine. And then here in the same patient that had surgery, that muscle is unfortunately now replaced with scar tissue and fat. And we know, unfortunately, naturally, after about 30 years old, we all start to lose the muscle mass in our back. And that becomes exponentially increased as we get past the age of 60. And this MRI kind of shows that on the very top left area, you have probably somebody in their 20s that has very healthy muscle around the spine. And then over time, that muscle goes away and gets replaced by fat. And we know lots of studies have shown that as we lose that muscle in our back, it leads to increased incidence of back pain. So if we compound this with doing big open surgeries that cause more scar tissue, you can see why people have a lot of back pain even after a successful surgery. So then that begs the question, well, are there any alternative options? And this is where the idea of minimally invasive spine surgery comes into play. So the goal of minimally invasive spine surgery is to accomplish the same goals as a big open surgery, but through smaller incisions, using specialized instruments and tools, and to ultimately lead to a better recovery and less side effects. So this surgery often involves using a tube-like structure. In this instance, this is a 2-centimeter tube with specialized instruments that can pass through this and allow us to do surgeries by sparing the muscles, preventing excess scar tissue, and accomplishing the same goal as the big surgery. And we can usually do this through an incision about the size of a paper clip, which is always nice. So, why have minimally invasive spine surgery? Well, if you think of all of the downsides of a big open surgery, the opposite is true of minimally invasive spine surgery. We spare the muscle attachments to the spine, so there's less scar tissue, less blood loss. That ultimately leads to shorter stays in the hospital, less narcotic use, and oftentimes patients can go home the same day, if not the next morning after surgery. And this is going to be another illustration of kind of the benefits of doing an open fusion, which will be on the right side, versus doing a fusion through a minimally invasive technique. When you look at the MRI cuts, you can see on the left, the patient that had the minimally invasive surgery still has all that paraspinal muscle still attached and looks healthy, versus the patient that had an open surgery, all of that muscle is now replaced with scar tissue, which will ultimately lead to a worse outcome down the line. So one of the surgeries, and probably the most common surgery that I do, is called a tubular decompression. So again, it involves using a 2-centimeter tube, spares the muscles, and I use these specialized instruments to get to the spine. This is kind of a cartoon demonstration of what we're looking at through this tube. The yellow structure here is usually the thick ligament that over time gets enlarged, pinches the nerve, and causes pain. And underneath that is the dura, or the nerve roots, which provide sensation and muscle function to all of our lower extremity. So this is, I think, a good example of a patient that did really well with this type of surgery. This was a patient in their 90s who had severe stenosis or narrowing of the nerves in their back. When you look in the image on the right side, this is what a normal MRI cut looks like. All of these tiny black dots are the nerves in our back, and they sit in a fluid-filled tube. Ideally, you want the nerves to have plenty of room to move around. When you look at this cut here, you can see the nerves are being pinched so tightly you can't see any of that spinal fluid, you can't see any of the nerve roots. In this patient, they were unable to ambulate for any amount of distance without significant debilitating leg pain and back pain. So using the tubular technique, we were able to get down to the spine. This is kind of the rough view of what we're looking at. The black arrow is pointing to that very thick ligament that is overgrown and is pinching the nerves. And then, once we're able to take that ligament away, you can see the nerve roots underneath. And this patient, despite being in their 90s, was able to go home 3 hours after surgery. And when they presented back to clinic, their leg pain was completely gone, and they had returned to their normal function without any assistive devices like a walker or a cane. And then this is kind of the surgery that I wanted to spend more time talking about. This is endoscopic surgery. So oftentimes people will hear of having shoulder scopes or knee scopes or hip scopes, and now we have the opportunity to do the same thing in the spine. So in this endoscope, there is a camera that gives you a bird's eye or a fisheye view of the spine. And through that same camera, we use specialized instruments to allow direct visualization of the spine and do pretty minimally or ultra minimally invasive surgery. So I'll show a video of what this entails. Can you unconnect your AirPods? Thanks. Was it playing audio on the AirPods? Okay, perfect.
Degenerative spinal disc disease can lead to a herniated disc compressing on a nerve, which is a common cause of pain.
There we go. All right.
And discomfort radiating into the buttocks, thigh, legs, or feet. For patients with a herniated disc causing nerve impingement or compression, an endoscopic approach is regarded as a highly successful procedure that may bring relief and restore mobility. For a centralized disc herniation at L5 to S1, an interlaminar approach is typically used to access the disc. During surgery with the aid of fluoroscopy or X-ray imaging, the surgeon will use a needle to mark the proper trajectory from the skin to the disc herniation. A guide wire will be inserted through the needle, and the needle will be removed. Dilators will be placed sequentially over the guide wire to then allow for the cannula to be inserted. Through this cannula, a specialized spine-specific endoscope is introduced to allow for real-time direct visualization of the tissue layer that covers the back side of the spinal canal. A small incision will be made in this tissue layer, or ligamentum flavum, to allow for the endoscope to pass through. Using the instruments, the surgeon will carefully push the spinal nerves aside to protect them and allow the disc herniation to come into view. Through the working channel of the endoscope, small instruments will be used to take out disc fragments of the herniation. An electrocautery tool will be used to cauterize the fibrous outer layer of the disc to prevent future disc herniations. Once the herniation has been removed, the surgeon will bring out the endoscope and may place a stitch or two to close the incision before placing a small bandage. By employing an interlaminar approach to a centralized disc herniation, your surgeon can reduce the risk of damaging soft tissue and muscle structures, and therefore can achieve a lower risk of infection and fewer post-operative complications, letting you return to normal daily activity sooner.
All right. So I thought it would just be useful to go through some examples of kind of what this looks like and the type of surgeries that we can do. So this was a patient in their 40s that was having multiple weeks of leg pain. As you can see, they have this large disc herniation, and you can compare it to, again, a normal MRI here. And here you can see a very, very large disc herniation pinching the nerves and causing significant leg pain. So this is a kind of a nice minute video kind of going through what we see with the endoscope. So here we're at the level of the disc herniation. We're using a special cautery probe to remove some of the tissue that's in our way as we're accessing the spine and the disc herniation. We use a specialized diamond burr to remove some bone to get down to the disc herniation. This burr is safe to use even on the nerve roots. So it's a nice instrument to use right around the spine. Once we remove enough of the bone, we'll use this, again, cautery probe to ensure that we've removed enough tissue to get access to the disc. And then again, you can see on the top of the screen, we've drilled all that bone away. And then once we're in the correct spot, we'll start to remove that disc herniation, usually the most satisfying part of the case. And then once that large disc herniation is removed, we'll be able to see that nerve root in very fine detail right at the top of the screen. And now you can imagine that that disc was underneath that, pushing that nerve up. And now that we've removed it, it has plenty of space. And there you can kind of see it pulsating on the top of the screen. There's really no other way to kind of get as good visualization of the nerves as you can with endoscopic surgery. Again, this was a patient was in the post-operative recovery for about 2 hours, went home the same day, and basically all their symptoms resolved right as they woke up after surgery. And so that's how much disc we were able to remove, and that's the incision on the left side. So again, pretty impressive surgery that we can do through that small of an incision. This is another example of a patient in their mid-20s that was having left leg pain and numbness for about 6 weeks. They had attempted therapy, injections, activity modification, and medication. Nothing was really working. So this was another good example for a patient that did well with endoscopic surgery. So we kind of localize where we're going to go with X-ray. That way we know exactly the part of the spine that we're targeting. This is the view inside, again, through the camera. You can see this very large kind of herniation bulging out and pushing the nerve roots up here. And that corresponds to this disc bulge on the MRI. And then again, this is what the view is during the surgery. And once we remove this large disc herniation, you can see actually the tear in the disc where that material was herniating or pushing out from. And then this is a visualization of the nerve root. So again, very, very hard to get a picture like this through any type of other approach to the spine. This is that nerve root that was being pinched. This is the center of the spine. It kind of corresponds to this diagram here. And this area is where that large disc herniation was that was pinching on the nerves. And then that's, again, we always like pictures of the incision. So about a 6 millimeter incision was all we needed for this surgery. And then same day surgery, again, instant resolution of the symptoms, or instant resolution of the pain when the patient woke up. Another example, again, patient in their 40s, again, left leg pain, had attempted and failed all conservative treatments, unfortunately. And so we had discussed surgical options. Again, you can see by that red arrow where you have that disc herniation that's affecting that exiting nerve root. These are some pictures from the surgery. So again, you can see this disc bulge or disc herniation here that's pushing these nerves here and this nerve out here. And this is just a close-up of that disc herniation. And so again, once we remove this large fragment of disc, the nerves have a lot more room. And it's, again, always the best part of the surgery. It's like popping a zit. And then this is what it looks like after. So again, you can see where that disc herniation used to be. It's now all gone right here. And then this nerve has plenty of space that it didn't have kind of before. And so we're able to take a good amount of disc material out through, again, a very small incision. And again, I'm just kind of beating a dead horse, but again, I think it's nice to see all these examples. This was a patient in their mid-60s, again, having right leg pain, numbness, tingling, some weakness, had attempted all conservative treatments, nothing had helped, and so they were, again, a good candidate for this endoscopic surgery. And then afterwards, again, you can see kind of the little tear in the disc where that material was herniating out from. And then that nerve root is now, sitting above where that herniated disc was, and now has a lot more room than it did before. And then again, you can take a lot of disc out through a very small incision. So, some of the benefits of endoscopic surgery. So I think it's a great procedure for people that have had previous surgeries on their back. It requires much less tissue dissection and much less dissection of scar tissue, and lowers the risks of any what we call dural tears or tears of the lining of the nerves. It's such a small incision that the infection risk is pretty much zero. It gives us some flexibility with anesthesia, especially for patients that may not be able to get full general anesthesia. We can do these under monitored anesthesia where we don't have to do a full general sedation or general anesthesia. And then very muscle sparing, like we talked about the importance of maintaining our muscle. With this type of surgery, there's no cutting of the muscle. That tube that we use goes down directly to the spine. And I think one cool image that shows the muscle sparing benefit of the surgery is you can see from the pre-op to the 1-year follow-up, without knowing ahead of time, there's really no way to look at this MRI and tell which side the patient had their surgery on, because the muscle is so maintained even a year out. So I think it's quite clear some of the benefits of this type of surgery. So in summary, unfortunately, back pain is something that everyone will probably deal with at some point in their life. It's unfortunately very common. It affects millions of people. Things to look out for are activity-related back pain, leg pain, numbness, tingling, weakness. And fortunately, there are minimally invasive ways to address these problems. This endoscopic surgery is certainly not for every type of patient, but I think in the correct type of patient, this can provide pretty significant improvement in their symptoms with very minimal disruption of the anatomy and the soft tissue. Thank you. Anybody have any questions?
During my career, I assisted on 2 laminectomies, and with microdiscectomy, I had to hold a nerve root retractor. I see with the tube, I don't know that there was room. Do you still use a nerve root retractor? Does that go down the tube?
Yep. So we can use a specialized instrument to help move part of the nerve root centrally, and then that actually cannula will put down and rotate, so that kind of acts as our nerve root retractor. So it both protects the nerve and then gets us exactly down on the nerves. I'll see if I can find that picture.
So knowing that, then you don't require an assistant during this procedure. You can do this all yourself.
I can, and I was joking with my PA that I don't actually really need him to be there for this. But yeah, so for this picture here, so you can see the top right of the screen, that cannula is kind of rotated to push the nerves out of view. So on the left side, that's where the nerves are going down the center, and then that cannula has now pushed them out of the way. So the only thing you're looking at is that disc herniation. So you can do all of that through this one kind of single cannula. All right. Yes.
In some of the examples, you were talking about the muscle loss.
Mm-hmm.
So is that exercise that can help with that? Or
Yep. So
patients were young?
Yep. So exercise is the most important thing that we can do, right? There's just going to be some component of muscle loss that's inevitable, but kind of exercising, weightlifting, having a high protein diet, those can all help kind of delay the progression of that muscle loss.
When do you decide to go the minimally invasive microscope to, as opposed to endoscopy? What variables kind of let you decide this patient is this, as opposed to that?
Yep. A lot of it will depend on the anatomy. So depending on if I can safely get that cannula in, how much of the bone I'll have to shave away to get the cannula in. If I'll have to do a lot of bony work, I tend to do that tubular surgery just because I can put a bigger drill, have a little wider field of view. So there's a little bit of nuance in that. I think these types of disc herniations, especially at L5-S1, are probably the best type of surgery. You have a big window to get the instruments in. You don't really have to manipulate the nerves as much, but it is very patient dependent.
To me that all this stuff, very cool what you could do with that. How come they can't fix spinal cord injuries?
That's a good question. So they are doing a lot of research on spinal cord injuries. The problem with when you have an actual injury to the spinal cord or the nerve roots, there's no great way to repair that type of cell, which is why they're looking into stem cell research. They're looking into different types of brain stimulation. But once that cell gets injured, it's not like other cells in our body that can regrow or regenerate. Nerves, once they get injured, we just unfortunately don't have any way to kind of treat them or recover. There's some of the research they're doing, especially like the Crystal Reef Foundation for like spinal cord injuries. They're making some pretty impressive improvements. It's not an easy thing to fix, unfortunately. Yeah, it would be nice. Yeah. Yeah, that's right. Yes.
So with all of this, you are manipulating the nerves a little bit, even though it's minimally invasive.
Mm-hmm.
So when the patient leaves, are the nerves angry? I mean, is it gone?
Sometimes you can get like what we call radiculitis, just inflammation of the nerve root after surgery. And so it's rare, but sometimes patients will have almost worse pain right after surgery because you're irritating the nerve root. Things that you can do to avoid that is, like kind of mentioned, minimal retraction or irritation of the nerve root, and then IV steroids have been found to kind of reduce that risk. So all my patients will get steroids kind of during surgery and then one dose as they leave. But that can certainly happen.
Have you ever used like dexamethasone or another steroid to, done with the procedure to shoot into by the spine so that the steroid can work as you close up the incision?
Yep, I'll do that. A lot of that just depends on how kind of inflamed that nerve root is. If it's a really inflamed nerve root, I'll put some steroid, and if it looks otherwise okay, I won't. I'll just give them IV. So there's not a great scientific kind of reasoning behind that. It's more I just look and see how kind of irritated it is, and then I'll decide based on that. But I have done that. All right. Well, I appreciate it. Thank you, everyone.
Thank you very much.